The National Pressure Ulcer Advisory Panel created a pressure ulcer root cause analysis template that is intended for the analysis and review of the development of stage 3 and 4 pressure ulcers or deep tissue injuries. Their template provides a review that may provide gap information indicating where there may have been a deviation from facilities' pressure ulcer prevention and treatment guidelines. Our facility currently uses this template to help identify system flaws that can be corrected to prevent the error from happening again in the future. I will briefly discuss application of this template, but for full details of the template, you can find it on the National Pressure Ulcer Advisory Panel website, listed here for your convenience. The first step in this root cause analysis was determining whether the injury to the patient's skin was related to pressure. In the case presented, the pressure ulcer was related to pressure, therefore we could proceed to the second step of the root cause analysis. This involved a systematic review of the patient's medical record data, including his date of birth, sex, date of admission, primary and secondary diagnosis, and finding out if the physician was notified of the new pressure ulcer. Did the physician's documentation reflect this notification? Was the patient and family notified, and was it documented that they were notified? The 3 steps of finding out what happened include discovery date and stage of the facility-acquired pressure ulcer. Step 4 of the RCA involves documenting the details of the event. For example, which departments were connected to the event, were pre-admission patient conditions documented, was the skin assessed upon admission, were pressure ulcer prevention protocols implemented based on risk score or Braden subscale scores, was the skin assessed at least every 24 hours, was there a change in the patient's condition? Was staff trained in pressure ulcer prevention? And was the patient placed on the correct support surface, offloading devices, seat, or cushion? Other questions to ask include, was the patient's nutrition and mobility status addressed? And was the facility-acquired pressure ulcer properly documented? In a review of the case scenario presented earlier, the answer to all the questions was yes. So, what was the cause of this pressure ulcer, and what can we do to prevent it in the future? Essentially, we did all we were asked to do based on our facility's pressure ulcer prevention protocol. Remember in my introduction, I discussed the scope and significance of pressure ulcers, and when reviewing the case scenario of this patient, he had many intrinsic factors that could have contributed to his pressure-related injury. First, he was sick for 7 to 10 days prior to admission with a poor appetite affecting his nutritional status, and didn't have much of an appetite during his admission either. Once he was intubated, he was started on enteral feedings, which addressed this aspect. He was on prolonged bed rest, immobile, and had poor perfusion related to kidney failure requiring hemodialysis, and poor perfusion due to sepsis caused by methicillin-susceptible Staph aureus pneumonia requiring vasopressors. All of these factors are what contributed to this adverse event, not a failure in the system. However, since this patient, we currently had another patient who developed a reportable pressure ulcer, and although she had similar intrinsic risks factors and system policies and procedures are in place as usual, we reviewed what we are currently doing for our patients. Upon reviewing, we realized that the only recent change we made to interventions in the last 6 months to minimize the risk of pressure ulcers was the addition of a repositioning glide sheet and a new incontinence pad that together, based on manufacturer guidelines, qualified as one layer. Management has decided to eliminate the new incontinence pad, also known as a chuck, and we will be monitoring if this small change will bring about change in the number of reportable hospital-acquired pressure ulcers in the ICU, which leads into my next method of quality improvement, the PDSA cycle.